Craniofacial dystrophy, part 2, Etiology and Pathology. The etiological factors, masticatory effort. Between the Neolithic and medieval periods, it was common to completely wear away the clinical crown by the age of 45. This seems incredible when we consider it today, that by the middle of the 4th decade of your life, less than 40 years that the tooth number 6 has been in your mouth, it could completely have worn away quite commonly. Since today, in modern society, this is a very rare event indeed. In fact, I've never seen it in all my career as a dentist, and I know many others who have not seen it either. And yet, between the Neolithic and medieval periods, the wear on that tooth, comparing tooth number 6, tooth number 7 and tooth number 8, is routinely and very accurately used to age a skull, as Brothwell describes in Digging Up Bones. It's a commonly used method of aging skulls from that period. And it is unusual for us today, but we need to remember that. This tended to refer more to people of middle and low socioeconomic status rather than people of high socioeconomic status who were able to eat a more refined diet and had less wear on their teeth. Returning to the text. This was due to a tougher, more fibrous, less calorific rich diet and non-nutritive uses such as leather processing and tool making. Comparing to modern attrition, this suggests a massive reduction in muscle usage over this time period. The effect of changes in the action of the masticatory muscles due to strokes, nerve damage, muscular dystrophy, and animal experiments on the anterior craniofacial structure, the ACS, is well established and well marked. This gives a graphic illustration of the classic type of wear pattern that was normal for hundreds of thousands of years prior to modern civilization. Now, I've mentioned in this first section of the etiological factors that there's a change in masticatory effort. We know from the change in muscle usage that this can have a great effect on facial form. Here are some classic examples. One is a cerebrovascular accident, a CVA or a stroke. The side of a face of an individual who's fully grown, who has expressed their full growth potential as much as they could many, many years ago. And this experiment of nature also affects only one side of the face, so it's controlled for by the other side of the face, but they have an obvious change in the whole skeletal form on one side of the face. This is also true of individuals with bilateral muscle weakness, some of whom have this weakness from birth, so affects them all the way through their development. However, make a note that this individual here with muscular dystrophy is actually biting on their back teeth, so attempting to keep their mouth closed. And this normal facial tracing is from a modern normal, not our ancestral or Mesolithic normal, which as we will discuss later, is significantly different. And here's an individual who's undergone a gross facial change, and there was no bone issue with Stephen Hawking. There was only a muscular issue. So we know the muscles can have a significant effect on facial form. And I mentioned there have been some significant effects with animal experiments. This is the work of Holl. He had taken some monkeys which don't normally have malocclusion. He has removed the muscle coming down to here, the masseter muscle. He has lifted this up. He's then taken the tip of the coronoid process, where the fan-like muscle here joins in to the tip here. He's removed this coronoid process, attached it to what we call the ascending ramus, the back of the mandible here. He's screwed that in place, then pulled the masseter that's still detached over this lump and attached it on the back of the ascending ramus. So he's changed the muscle action on these individuals. And you'll see this has a dramatic change in the facial form. It appears as if the mandible just swings upwards, almost in the opposite direction of the other examples I just gave you. But by strengthening the muscle, whereas these were weakening the muscle, this has moved the whole mandible up and forwards, and it appears that the small bones of the face have been pushed forward and outwards, whereas there was very, very little change in the actual mandibular structure itself. It's no longer, it's no shorter, and the only significant changes we notice is a change in the coronoid process, which he cut off, and a change in the area here and here, which obviously a muscle has been removed from here and it's been added to there, which is an interesting point and serves that the main change is within the anterior section of the skull, with lots of changes even in the position of the jaw joint. So whereas it's not so much a change in the mandible, it's a change in all of the bones between the top jaw and the bottom jaw. Okay, returning to the text. As I'd said, these effects on the anterior craniofacial structure were well established and well marked. Now the second effect is posture. Over the last century, and certainly for the last decades, the incidence of nasal congestion has risen considerably. I give an article, a reference that just supports that fact. If the nasal airway is blocked, then the tongue and the mandible are lowered, the lips are separated, and the head is postured forwards. This is in order to breathe, which is an essential requirement. And this was well covered in an experiment by Peter Vig on dental students. He used a clip to block their noses and then watched how their head posture changed. Instantly after placing the clip on their noses, the individuals lowered their tongue and opened their mouth in order to breathe. If they hadn't, they'd have asphyxiated. Following this, they tip their heads backwards. Simply opening the mouth makes it a little uncomfortable in the airway, since the mandible has hinged backwards into the airway, taking the attachment of the tongue with it. To compensate for this, the individuals tip their head back slightly. Then, after a short delay that varied amongst the individuals, they tended to re-establish their head position, but in a more forward head posture with the mouth open. In effect, they had gone from this to this to this. So net effect from this to this. And it was quite a consistent pattern of behaviour. While initially this facilitates breathing, the change can become habitual. At puberty, as individuals become socially aware, lip seal may improve, but it appears that the tongue to palate posture is rarely re-established. The effects of this change in the mode of breathing and the tongue position in isolation on the anterior craniofacial structure are unequivocal. So, when I say the effects of a change in the mode of breathing, I'm referring mainly to the work of Harvold and the work of Linda Aronson. Harvold used silicone plugs in the noses of monkeys, which changed them into oral breathers. It's interesting to note that a number of the monkeys refused to breathe out of their mouths and asphyxiated when they came round from the anaesthetic. Of the remaining monkeys, they all developed malocclusions of some sort when they were forced to breathe out of their mouth. Linda Aronson took a group of individuals who had enlarged adenoids and couldn't breathe out of their noses if they tried. Having removed the adenoids, he then separated the group into those that now could breathe out of their mouths, out of their noses, and those that continued to be unable to do so. And he watched the growth patterns change to two significant standards of deviation. A very, very, very significant paper, although the findings were relatively small. I think it gives some evidence of what is possible rather than what is happening in normal individuals. This also graphically illustrates a child who soon after this photograph gained complete nasal obstruction due to an allergy. Although the allergy was later cured and he was able to breathe out of his nose, he didn't do so and continued to hang his mouth open and downwards, dramatically affecting his facial pattern. So these are clearly suggesting that a change in breathing can have a marked influence on the growth pattern. And then I mention that the tongue posture in isolation. Well, this was one of my favourite studies done by Harvold, in which he placed a wedge of acrylic. He sutured it into the roof of the mouth that made it uncomfortable for the monkeys to place their tongue on the roof of the mouth. They then hang their mouth open, but not due to breathing, because they could still breathe through their noses. That was completely unaffected. But it was a well-done study with 18 controls and 18 experimental monkeys, age and sex matched. None of the control monkeys had anything from near perfect occlusion, where all of the experimental animals had severe skeletal and dental malocclusion, something we don't need statistics to prove. It's clear, black and white, and gives a graphic and good illustration. Also, of course, this shows a downswing, whereas Hull showed an upswing, which in scientific terms is nice when you can do both directions and show them clearly, if with slightly different experiments. I next move on to the swallowing pattern. In an ideal adult swallow, the tongue should push upwards, outwards and forwards on the palate, and the perioral musculus should be passive. For this, I quote Barrett and Hansen, and I'm quoting Jones, the normal and abnormal swallowing. I think I just needed a reference. This is, I think, within the myofascial functional therapy circles and most of orthodontics quite well established fact. However, this now seems rare, with most individuals displaying some perioral activity, such as a suckling-like swallow that pulls backwards and inwards on the dentition and does not support the maxilla. The teeth and alveolus are pulled inwards and backwards, reducing the tongue space. The suggested cause has been a lack of breastfeeding. However, the author, Mew, also proposes the early introduction of semi-solid foods before the adult reflex is fully developed as a factor. I think, although breastfeeding has long been suggested as the main cause of this, I feel that this concept of baby-led weaning may well hold future avenues of experiment and discovery, since if you give a child a very soft food substance that it can suckle, before it's learnt to do a correct adult swallow, it will attempt to suckle that food substance, and it may well not change its pattern if that proves to be effective, which for most modern foods it is very effective. Now, the compensatory mechanisms. Having established the etiological factors, this is a little more of a discussion of the pathological process. Changes in the shape of the anterior craniofacial structure disturb many of its functions, some of which, such as breathing and swallowing, are vital. To facilitate these, certain compensations are possible, which vary at both the group and individual level, influencing both the signs and symptoms of craniofacial dystrophy. So as the muscles weaken and the mouth is postured open, the craniofacial structure lengthens, narrowing and shallowing, affecting its functions. And certain compensations are possible to allow or help the normal functions continue. The head can be postured forward by flexing the neck while maintaining the inclination of the head. This opens the airway by extending the head. This is more or less what I described as Peter Vig's experiment previously. This general posture. The tongue can be moved up out of the airway, usually with some of its bulk placed between the teeth in a variety of positions, affecting the mandibular position, which I refer to as the tongue effect. So the tongue is mobile as the anterior craniofacial structure lengthens and narrows and shallows. The cross-sectional area is reduced. That's the space for the teeth is reduced, but also the space for the airway and the tongue. The tongue can be repositioned to move it out of the airway, which is what we refer to as the tongue effect. Then the mandible can be lowered and postured forwards, backwards, laterally, or remain central. It is influenced by the position of the tongue and the need to maintain a comfortable intercuspal position, which I refer to as the mandibular effect. People feel comfortable biting together into a certain position. The exact nature and sequence of these compensations is not clear. However, some exacerbate their causes, creating self-reinforcing vicious cycles. For example, both the change in swallowing pattern and a lowered maxilla reduce tongue space, encouraging a tongue between tooth posture, which encourages a suckling-like swallowing pattern and reduces support for the maxilla. Thank you.